Thank you very much for allowing me to be here. Good morning, everyone. And let's just get a quick showing of hands. Who here in the audience is doing laparoscopy on a routine basis? Okay. Who here are using enhanced recovery protocols on a routine basis? Okay, so there's a significant number here who are doing laparoscopy and not using enhanced recovery. So I'm going to go into this a little bit because my initial thought a few years ago was like, hey, I'm doing laparoscopy, I'm being as minimally invasive as I can. I was doing single incision surgery, and then I was challenged to look into this further. So I have no disclosures. So just thinking about technique. Most of the people in this room are minimally invasive surgeons. Why should we be thinking about enhanced recovery? Well, let's go back to basics. What do the guidelines suggest? We want to maintain nutrition. We want to maintain normal fluid and electrolyte balance. We want to maintain mobility. The longer the patient's in bed, the more muscle mass they lose. And we want to maintain their equilibrium. We want them not to be in pain. So using ERAS, if you go through and look at the data, it's evidence-based medicine, shows that it can reduce time of care by 30% and reduce post-operative complications by up to 50%. Very nice review here really emphasizes one of the main points is the vast majority of the early work on this was done in open colorectal surgery. So if you look at some of the earlier trials and look at that second to last column, this one that says LAP, only one of those studies had any laparoscopic patients in it. Did show a benefit. The other issue when you look at those trials, if you look at the column that's headed number of elements, many of those studies early on were actually not really looking at the full program. Many of them were looking at the elements that could be controlled by the surgeon, but were not under the control of the anesthesiologist or the nursing staff. So what can the surgeon do? Well, we know, as members of SAGES, that with laparoscopy, by making incisions smaller, you benefit the patient. There are other ways of modifying surgical incisions, such as transverse incisions, and as I mentioned, smaller ones. And even within laparoscopy, there are a range of incision sizes. Hand-assisted, obviously depends on the size of one's hand. Robotic, the ports are actually larger than the 5mm ports used for standard multi-port surgery. Then you've got multi-port and then single incision. And many, many studies on laparoscopy have shown the benefits in terms of less pain, resulting in reduced narcotics, a shorter period of postoperative ileus, reduced fluid losses, and reduced perioperative stress in terms of the release of stress hormones at the time of surgery. One of the earlier studies to show the benefit of combining laparoscopy and enhanced recovery was this nice study, multi-center study in the Netherlands, headed by Willem Bemmelman. They included 9 centers looking at segmental colectomy, so keeping it simple, and had 4 arms to their study, lap and open, combined with either what they call fast track, which was enhanced recovery, or standard care. And their primary outcome was length of stay. And you can see the secondary outcomes there. And again, very nice study. It was powered with 400 patients to show a difference of 1 day in the hospital. So laparoscopy and fast track had median stay of 5, open and fast track 7 days stay. Laparoscopic and standard post-op therapy was 6, and open and standard therapy was 7. In multivariate analysis, regression analysis, they showed that the optimal treatment for the patient was a laparoscopic resection in an enhanced recovery protocol. And open surgery, if that was the only option, if either the surgeon didn't have the requisite skills or the patient was judged not suitable for open surgery is also best done in an enhanced recovery protocol. So there are other trials looking at the role of laparoscopy combined with fast-track elements. So this was a very nice study from a major laparoscopic center in the UK that when I started reading it, I was thinking, well, how did they ethically randomize patients between laparoscopic and open when they are a laparoscopic center? But reading the study, the reason they were doing this to show, do the benefits of laparoscopy still exist? I mean, do we still need to push people to learn laparoscopic techniques if the outcomes of surgery are actually optimized by the patient being under an enhanced recovery protocol? So it's actually a very nice study and ethical. So they randomized patients with colon cancer to lap or open within a protocol, stratified them as you see here. The primary outcome I actually thought was a bit dodgy, physical fatigue at 1 month. That is not a standard outcome for most surgical trials. But the patients and the assessors were blinded, and they had independent review of both the specimens and the results. Reasonable number of patients, around 100 in each arm from 12 different centers, and they found that the 1 month fatigue scores were similar. Not a big surprise. The median length of stay was shorter after laparoscopy than after open, but there weren't any differences in other secondary outcomes. So they concluded that patients who were treated by experienced surgeons under an enhanced recovery protocol had shorter length of stay when it was done laparoscopically compared with open. So there were still benefits of combining the two. Even though the open patients had benefits, the laparoscopic patients still had a shorter length of stay. Another issue being looked at in laparoscopy, one of the standard aspects of multimodality care in open surgery has been either spinals or epidurals, but the role of epidurals in laparoscopic surgery has been contested. So this study aimed to look at that. And they looked at epidural anesthesia versus PCA in an enhanced recovery program, and showed that in the epidural group, the median length of stay was 5 days as opposed to 4 days in the PCA group. The PCA group, interestingly, had fewer complications, mainly related to hypotension in the epidural group and the need for vasopressors, and no difference in pain scores, which was interesting. So the authors concluded from this randomized trial that epidurals actually do not have a benefit within an enhanced recovery protocol when used on laparoscopic patients. So that's a good take-home point. What about epidural versus a tap block? Again, are epidurals necessary? But okay, let's compare it with the tap block, which I think there is a general feeling that a tap block can certainly enhance post-op pain control and may give better pain control than PCA, although obviously the previous study didn't show that PCA was inferior to epidural in terms of pain control. So this is a smaller study, 35 in each arm, looking at continuous tap block, which is somewhat different from the way many of us practice it with a single intraoperative shot bilaterally versus epidural, and looked at the use of paracetamol, I will translate for you, that's acetaminophen, and diclofenac and PRN tramadol. So there's just a little bit, both groups got their version of bupivacaine. And the outcomes were looking at visual analog scores. And so there was no significant difference between the groups. And continuous tap infusions, this is not the same as a tap block, but a tap block performed with a long-acting local anesthetic may give the same benefits. So again, this is showing there's no inferiority of a tap block compared with epidural, which in the previous study may actually slow things down. So again, coming back to tap versus placebo, standard study, randomized, both arms of the study under an enhanced recovery protocol. And the TAP block patients had a lower pain score in the PACU and used fewer opioids. Throughout the stay, the TAP patients had a lower score, and interestingly, no difference in opioid use throughout their stay, but the length of stay, although shorter in the TAP group, was not statistically significantly different. So the challenge then, I think, that the nicest study there was that multi-center randomized one from the Netherlands. But can enhanced recovery really add to laparoscopy? Is it worth it for a laparoscopic surgeon to start going through all the steps necessary to bring the groups together to form a multimodality group to start doing an enhanced recovery program? Because that means bringing together many components: anesthesiologists, CRNAs, pre-op, intra-op, post-op, floor, nursing staff, IT. Many people are involved in getting a program to work. And where I was challenged on this was Professor Ole Lundqvist, who was one of the founders of the ERAS, or Enhanced Recovery After Surgery Society, saw me give a talk on single incision surgery and challenged me to see if enhanced recovery would make a difference. So this is my own experience with it. So this is a single incision proctocolectomy and J-pouch done through the ileostomy site. Once we started doing single incision, and it was selectively, and we compared our first 50 single incision patients with patients undergoing multiport colectomy for the equivalent procedure. And we showed actually there was a reduction in operative time, which surprised us, but also a reduction in length of stay. So the yellow graph here is the outline for the length of stay for multiport patients, and the red for the single incision patients. So you can see that the single incision patients, the whole curve is shifted to the left, meaning they were going home sooner. So we put together our enhanced recovery protocol and put all the elements together and had a single go-live date so that everyone was on board. And this was July the 1st, beginning of a new year with a residency program. You know what that's like. So maybe part of this was having an electronic protocol that the new interns couldn't mess up. It was there. They had to do what they were asked to do. And so for some of the data, we compared the first 6 months of 2013 with the second 6 months, so before and after. And some of the other data you'll see here, we compare the first quarter after going live with the equivalent quarter of the year before. So this was kind of amusing when it came through, because this is the data for 3 colorectal surgeons. And so in the third column, the average length of stay for all comers, all abdominal surgery, for these 3 colorectal surgeons was looked at for the first 6 months compared with the second 6 months. And the person who had the shortest length of stay already took the greatest amount off their length of stay because they were most compliant with the protocol. Another surgeon who was kind of, I like some of the elements, not all of them, but we do some of them, knocked some length of stay off their average. And the surgeon who was firmly rooted in the beliefs that he'd learned in residency 30 years earlier wouldn't budge, and neither did his length of stay, because he would have the residents unclick some of the pre-click boxes on the electronic order set. The other thing that surprised us when we're looking at the data is looking at, this is pre-going live for the same quarter. Average length of stay for laparoscopy was 5.8 days, and for open, 8.2. Pretty standard data across the country. For the laparoscopic group, after going live, the average length of stay dropped by over a day to 4.5. But the biggest surprise that we saw was that in the open group, we went from 8.2 days to 4.8, almost similar to laparoscopy. So does an ERP program has an impact, and maybe has the biggest impact on open patients, but it also has an impact on the laparoscopic patients. So laparoscopy plus enhanced recovery still gives the best results. So this is that graph I showed you before of multi-port single incision, and I apologize because my institution changed our PowerPoint package somewhere between the first and second graph, so I had to use different colors, and I couldn't reproduce it. But the blue graph now in front is the impact of enhanced recovery on multi-port. In fact, I've been so fascinated and intrigued by the results of enhanced recovery, I've stopped doing single incision because it's not necessary to achieve these results. This is looking at some of the financial data, and this is just alphabetically the list by which the costs in my institution are broken down. The ranking here shows going from most expensive, so patient care services, with the second one being hospital surgical service. And this shows these two columns show the percentage reduction in costs. So in terms of the laparoscopic group, costs were reduced anywhere between 4 and 14% in those various categories. So there's still improvement, even with laparoscopy and enhanced recovery. The two together go best because you can still make improvements. But again, the eye-opener, we're seeing some of the cost savings in the open group, which ranged from 12% reduction in costs to 35%, primarily because of reduction in length of stay. This is something I'm just throwing out there. It was an unusual piece of information that I hadn't heard before, and it came up at a CME course we were holding last month. And we had 2 speakers from the UK, from Guildford. One was Mike Scott, who's an anesthesiologist, and the other was Tim Rockall, his colorectal surgery colleague. And together, they've actually been at the forefront of the move in the UK to introduce enhanced recovery. And one of the things I find fascinating about the UK is, like, I went to medical school in the NHS. I used to think of it as a dinosaur and a fossil. But you know what? The NHS, several years ago, mandated that enhanced recovery be included in its hospitals. Mandated it. We don't have anybody in the US that can do that, so we have to take it upon ourselves to use evidence-based medicine. What this shows, and this was a true eye-opener for me, if you look at that top line, those were patients who still had post-op complications on day 15. By 10 years, so the end of the graph, 4,000 days, they had close to 100% mortality. So how do we reduce complications? We use enhanced recovery. We use goal-directed fluid therapy. We use multimodality pain control. We use the other components of an enhanced recovery protocol, and we use minimally invasive surgery. There's proof for all of those that they reduce complications. Because if you look at that patient who's still in a bed 2 weeks in the hospital with a complication, it's incredibly humbling and eye-opening to think that these patients have close to 100% mortality 10 years down the road because of something you just did to them that you might have been able to avoid if you'd used a different protocol. So can enhanced recovery add to laparoscopy? Undoubtedly. And can laparoscopy add to enhanced recovery? Indubitably. Thank you for your attention.